All right, good afternoon, everyone. Can everyone hear me okay?
Yes.
Hi, Lynn. We sure
Yeah.
can.
Awesome. Thank y'all so much for joining. I said we have a lot of people on today, so I appreciate you. I know May is a very, very busy month. Happy Trauma Awareness Month, Trauma Registrars Professionals Day, Nurses Week, Hospital Week, EMS Week is coming. So I know all you are extremely busy, but hopefully y'all can take some time off to celebrate yourselves and all that you do. So we do appreciate each and every one of you. We will go ahead and get started since we do have a lot to cover today. Let's see. So I know, Kendra, we need to establish a quorum.
Yes.
I know Crystal's on the call. She just can't talk right now.
Okay, that's good. So just to ensure everybody's here, Education Subcommittee, Julie Freeman.
Here. Good afternoon.
Good, hello. Pediatric Subcommittee, Kelly Roker. Okay. So I don't hear.
I'm here, Lynn.
Oh, hi, how are you?
I'm good, thanks.
PI, either Rama or Ashley Bullington.
It's Rayma, I'm here.
I'm here.
Great. Oh, great, thank you. Registry, Kelly Vaughn.
I'm here. I'm here.
Okay. And injury prevention, we said that Crystal's here. So, Madam Chair, you have a quorum.
Nice. Thank you all. Very good. So earlier in the week, Gabby sent out the minutes. So we need to take a minute to approve those. Hopefully everyone had a chance to review those from our February 19th meeting. So if we can get a motion to approve those.
Motion to approve. This is Ashley Bullington.
All right. Thank you, Ashley.
I did see one correction that needed to be made.
Oh.
Sorry. When it was talking about the members present, Julie Freeman from Wellstar Kennestone was actually marked as being from Grady. So
Good eyes.
corrected. Thank you.
Good eye, Kendra. Thank you.
Okay. So with that one correct, were there any other thing that needed to be changed? Did anybody see?
I did have to add Karen Hill to the attendance, so that is in the edited version, and I will correct Julie's
Really?
organization.
Perfect. All right. Anything else? Okay, so I guess we need to make another motion to approve the minutes with those additions of Julie changing her from Grady to Kennestone and adding Karen Hill.
Move to approve as amended.
All right. Thank you, Kendra. Do we have a second?
Second, this is Ashley.
Thank you, Ashley. I guess we'll take the cricket silence for our approval. And if anyone opposes. All right, hearing none, we'll approve those minutes with those changes that mentioned earlier. Thank y'all. All right, do we have any new members that have never been to this meeting before on the call today?
Nobody wants to be called out, Lynn.
I guess not.
I'm sorry, I was trying to find my button. I'm new. I'm Stephanie Verna from Grady Memorial.
Hey, Stephanie, welcome.
Thank you.
So what do you do at Grady?
I work on the Shattered Dreams program with Lawrence Blair and the trauma team. And I'm actually formerly from iPrice.
Oh, okay.
So I was a program manager there. So thank you for
Awesome.
hanging out.
Yeah, thank you. And welcome. Anyone else? Okay. All right, well, moving right along. Liz, do you have the update for the Georgia Trauma
Hey,
Commission?
Lynn, I'm sorry. There was somebody in the chat who was new,
Oh, sorry, I can't.
who doesn't have audio, but we have somebody new from, where is it?
Oh, I see it. Piedmont.
Athens.
Yes, yes. So,
Welcome, Eva. I can see it now. Okay. All right, Liz.
Okay, thank you very much, Lynn, and happy Nurses Week and all the weeks coming up. And again, as Lynn said, I know you guys are so busy in Trauma Awareness Month, it all piles on at the same time. I just have a few updates for you guys. As you know, we have the commission meeting, the full commission meeting is next Thursday on the 15th. So please tune in for that just to listen in. Lots of great information, all the subcommittee reports out as well as our system partner reports. But the big news is that if you remember back at your February meeting, we noticed that in the budget that was released by the governor's office, we had the additional 4 million included in there again for the FY26 year, and it did pass with the additional 4 million. So very exciting. We are working right now on your contracts and just want to give you all a heads up that contracts for 26 may be a little bit delayed. We're doing kind of a overhaul and we just had a call about it. Katie's been working diligently on this with our external legal advice. In fact, the lawyer that helps us with all the peer review stuff, since a lot of your pay for performance ties into a lot of GQIP things, we just want to make sure from a legal perspective that that language is all firmed up and a little modernized and, just make your contract more easy to navigate. So, so we'll update you when we anticipate release on that, but we're still working through a lot of the exhibits and attachments. And again, really want to streamline it for you. We don't want to make this hard for sure. And trying to work on a process where the renewal can be a little bit more streamlined. And then also yesterday, Gina and I joined Qcentrics for the kickoff for the level 4 inter-rater reliability program, where we're actually going to have Qcentrics is a company that is very much in the space of quality improvement, and they do contract abstraction. And so they are going to do inter-rater, since a lot of level 4s don't have access to resources to do inter-rater for them. So that was approved last year. Finally, it takes so long to work through the contract piece, but we're kicking that off, and they are going to start reaching out to those of you who are participating in that program about getting your implementation done. So, and they're going to keep us advised on how that process is moving forward. I know with your IT folks, even at the smaller facilities, this is like trying to get the keys to the Porsche, it's really hard. So we do anticipate that it might take a minute. So so just be patient and we'll get that program up and running. GCC meeting, I already told you about that. Julie will probably talk about this a little bit more in her education update, but I just wanted everybody to know that the STN orientation slides that were approved for purchase, we had to work on language that's going to go on the slides, because I want it to be clear to everyone that this isn't share with friends and family. This is just for internal trauma center use only. I think you're all really going to like the full product when you see it. But STN is going to put language on there that it's restricted for use within the Georgia trauma centers only. So they gave us a pretty good price for a statewide program, so that all the trauma centers in the state could have access to these orientation slides, and they are editable. Julie, I'm sure will tell you much more about that, but I just want you to know we're just waiting for payment to be applied to our account with STN, and then they will release the slides to us with that language on it, just so everyone is clear. And then last two, one is that the performance-based pay revisions that were approved by the PVP program that you heard about or the PVP work group that you heard about in February, were approved by the Finance Committee. They will go on to the commission for approval on the 15th. Most of this is actually going to help you, because if you recall, we're doing tiered meeting attendance now, so that it won't be an all or none situation for if you don't meet a certain threshold, you get everything taken away. It'll be tiered, so it'll be a little bit easier for that. And then we kicked off our readiness cost survey, and we're really excited about that. We had our first webinar on Tuesday. There's a few other, and these are optional webinars just to bring your questions. And thank you. You guys are bringing great questions. Gabby has a whole webpage devoted to the readiness cost survey with all the resources that you could ever want. And she's updating the FAQ document, all the, to be able to access the webinars, et cetera, just go to the, it's right on our landing page. So you can't miss it. It looks wonderful. And it's a one-stop shop for everything related to readiness. So Lynn, that's my attempt to do a abbreviated update for the commission meeting or for
That's great. Just to clarify, the readiness cost survey, that's for level 1s and 2s, correct?
Oh, thank you. Thank you so much. Yes. For level 1s and 2s, you all know we did the level 3s and 4s on 2029. We actually only did it a few years ago, but we did it on 2029 financial data because we wanted it to be before the crazy COVID thing. But the level 1 and 2 centers, the big reason for doing it right now, well, first of all, it's been a while. It's been almost 8 years since we've done it. We did it last on 2016 financial data, but now you're all verified. So we want to try to, the twist for this time is to see if we can demonstrate what a cost is associated with and Gabby just put the timeline up for you there. Gabby, was there any other slides you wanted to go through for everybody? I know I just gave a high level of overview because I know they're going to hear it all again next week at the commission meeting, but we want to try to assign a cost to, does verification increase your readiness cost? There will obviously be inflationary increases just because it's been almost 10 years, but certainly there are accounting ways to deal with inflation, and then we can just try to figure out. And so you see Gabby has that nice little pin you are here. My gosh, that looks great. Anything else, Gabby, you want to comment on that?
Not for the readiness cost survey. I just want to bring attention to the PBP, where the biggest changes happened from the open comment feedback period. For level 3 centers, we did add registrar virtual attendance for the National TQIP conference. And then for level 4 centers, we did remove the NTDS data submission requirement. So those are just the 2 big changes that happened from the open comment period. And I did send you everything otherwise for you to review in the meeting reminder, and I'll send it again after the meeting if you wanted to have a light read.
Thanks, Gabby. And Gabby is leading both these efforts, and she's keeping us so organized, and all of it is so easy to navigate. And I think you'll all be really pleased with it. And for the level 4s, yes, you're not getting anything from submitting your data to NTDS, and ACS knows about this. I don't know, hopefully for the future, there is something planned for you to be able to get some kind of report back. There is no risk adjustment program for level 4s. Hopefully we're going to have that soon with Arborometrics. Gina will give you a little update on that. But if something becomes available from the ACS, we're always early adopters and we will jump on that bus. But for right now, it's just not worth your time and effort if the data is just going into a black hole and you're not seeing anything from it. Unless there's questions, I think that's all from us, Lynn.
Thank you, Liz.
Thank you.
Crystal, Shelnut, do you have an RTAC update?
I do have an RTAC update for you. So a couple of things. First, we have made significant progress with Region 9. I believe I discussed with the group last time, we've identified a new coordinator who started early this year. We now finally have a chair and a committee that's been established down there. They've got some exciting projects that they're looking to take on. And so we're very happy to have that committee back up and running and having some meaningful opportunities ahead of them. We've recently interviewed for the Region 8 RTAC position. We expect to have an announcement on that soon. So I look forward to updating everybody on that. And then a couple of initiatives that all of the RTACs are engaging in that I wanted to provide an update on. So the first, we've been working with Gina and GQIP to develop some data reporting that goes to each of the RTACs every quarter before their meeting. And so the goal is to provide them with some meaningful data that allows them to kind of create opportunities for their performance improvement projects or education. So some of the information that's being presented to them are like the total number of patients entering the registry from their region, mortality mechanism, patient ages, what are the injury severity scores, and then some other things that we're tracking like average scene times for critical patients and some things like that. Already, even with just 2 report outs to the regions, there's been a lot of kind of really meaningful conversations in the RTACs, and then also some projects that are starting to emerge from the reporting that's coming from that. So we definitely appreciate all of Gina's efforts, and we think that's going to continue to be a great initiative for the RTACs. Efforts continue on the Stop the Bleed program. They should be distributing kits right now from our last application period, and we anticipate opening back up applications in June. So we've got a commitment for continued support for that project from the commission. And so the group will be receiving more information, kind of our little one-pager on the Stop the Bleed program when the applications open back up. So an update on the EMS Educational Needs Assessment. As many of you will remember, that was a big project taken on by the RTACs early this year. We had a really great response to that survey with over 1,200 people participating in it. We had 3 different surveys that went to EMS, to providers, to EMS leadership, and then to our hospital partners. And the amount of information coming out of it really is just tremendous. So we asked questions about, for the providers, like what type of education do you want? Do you want online education, hands-on? What's an ideal time frame? You know, just those types of kind of nuts and bolts about education. And then we talked a lot about content. So what are some of the things that they felt like they needed more training on consistently across the state? We saw themes of needle decompression, trauma resuscitation, and pediatrics. Those were near the top of everybody's list. So the RTACs are again kind of crafting some education specifically to address concerns that they found in their region. And so we'll see more of that over the next 6 months or so. And I think that's it for my update. We've got a couple of conferences that are around the corner for the RTACs. So May 22nd, the Region 10 RTAC is having its 3rd annual UGA Sports Medicine Conference. That'll be at the UGA practice facility. Really great speakers for that. We've got an instructor and provider conference hosted by the Region 10 RTAC that's at the end of August. And on October 3rd, the Region 2 RTAC is going to have their 10th annual Northeast Georgia Trauma Conference. So we hope we'll see you guys participating in each of those. And that's all I've got, Lynn.
Thank you, Crystal. I will say the RTAC reports that y'all shared. I know our last RTAC meeting was last week, and we reviewed our region 5 times with other times in Georgia, and it was very interesting to me to see that not just the times that you mentioned, EMS scene time and stuff, but mechanism injury, the ages, the ISS scores. It was very interesting. It very much so that it made me, when I came back Monday, I actually got into Arbormetrics and was trying to figure out how to get it for Fairview. So Gina, I'll be calling you soon. So I really think it's very meaningful, and I think we got some good feedback from our meeting for that too. So
good. I'm glad to hear
that. For that. Yeah, it was good. All right. Marie, Office of EMS and Trauma.
Good afternoon.
Okay.
Good afternoon, everyone. I'm Marie Probst, and for the update on the OTCPE reports, I just have a few bullet points for you. We are still reviewing the Q3 reports, so I don't have any data to report out on those yet, but so far the level 1s and 2 centers quarterly data and calendar year 24 data looks like it's meeting the standards. So we're pleased with that. We're still working on the 3s and 4s. So I'll have more information on the performance later. Just as a reminder, TPMs, please prompt your TMD to log in to the license management system and sign the TMD attestation forms. I was working on some of these reports this morning, and so there's a backlog sitting in the system waiting on the TMDs. So if you would help us out with that, that would be great. And the form will push on over to Stacy's side so she can do her trauma system coordinator review. Just a little point about the Q4 report. It will open June 15th. And then during the summer, July and August months, we will be revising the fiscal year 2026 OTCPE and OBCPE. So if you have any comments for those, please let us know. And that's all I have. I'll turn it over to Stacy.
Good afternoon, everybody. I wanted to echo the Happy Nurses Week. Congratulations to all the nurses out there. We do a lot. Y'all do a lot. And our patients, thank you. I also want to just say thank you to all the trauma team and staff that's on this meeting. Without each and everybody's job, the programs would be successful. So I just want to say thank you to all the programs and staff. I know the work's tough. I know sometimes you feel like you're just behind the scenes in some jobs, but it really makes a difference and saves lives. And I just wanted to say thank you for your heart and dedication. For the Office of EMS update, we are still working with the Trauma Commission to update our trauma state plan. We're going to be meeting next month to just discuss some things and prioritize some areas for improvement. We are open to schedule any designation or verification consults this year of 2025. So reach out to me or Marie or the trauma email at dph.ga.gov, and we can set up a consult and discussion. We're excited in the progress that the 2 facilities are making that are seeking level 4 designation in Region 9. And I wanted to congratulate Liberty Regional, as I hope Tammy's on the call. They are our new level 4 designated facility. We kind of already knew because they discussed it, but we want to congratulate doctors also as being ACS verified and state redesignated as a level 2. And then Advent Health Redmond was also ACS verified and redesignated as a level 3. And we just finished 2 weeks ago our designation with Wellstar West Georgia, and they are redesignated as level 4. So congrats to all the designations and redesignations. Y'all are doing awesome things. It's great to go out and see y'all's facilities and see y'all's programs and all the work and passion that y'all have. The only other thing I was going to mention at this time, Marie mentioned Q4 OTCPEs will be rolling out next quarter, but we wanted to start seeing if anybody wanted to add any additional items to the OTCPE. We want this to be something that you benefit from, that we benefit from. I feel like we did well with putting the expert process on there. It's allowed a lot of centers to kind of phone in on reaching that 80% compliance because you're actually graphing it out each quarter and you can kind of see what messed up one month or what's going on. And if you're meeting that 80%. So if there's any other standards or any other information that you think would be beneficial for the OTCPEs, just please reach out to us. We'll be happy to add them rolling forward in the fiscal year for 26 on that Q1 report. And that's all I have for now.
Thank you, Stacy. Is there a deadline that you would want those items to?
Let's see. Marie, we roll, I'm not looking at my calendar. Usually we, by July, I would say. Is that good, Marie?
Yes. If
okay.
everybody could give us their feedback or suggestions for it by the beginning of July, that would be great because we'll start working on revising the fiscal year 26 form in July and August. We'll finalize it.
I was gonna talk to Marie. I noticed when I was doing some of the reports this last time, we still have some of the old standard numbers, so we're gonna update that. It was out of the orange book. So we want to update it and we want it to be beneficial to the centers. So yes, please send any recommendations or suggestions by July.
Okay. Perfect. Thank y'all. So for Cheryl, she was unable to join today, but she just asked that she does not have a report to give. She's getting ready for the Ties of Change in Trauma Care. That's that will be held on May 17th at the Georgia Aquarium. Hope to see lots of you there. I'm excited about it. And she also said that she will just continue to work very closely with Julie and the education subcommittee to guarantee the continued success with the rural continuing education program. So that was all she had. So, Gina, do you have a report for GQuIP?
I do. Thank you very much, Lynn. I will start with Arbormetrics update. All of calendar year 2024 data is loaded, so you should be able to see that in the GQuIP site. The risk adjustment model build is pretty much complete, and it's in our user acceptance testing site. Myself and Dr. Smith and Dr. Ayan Chi can see it. So we're working out the kinks with that before we move it to what we call the production site, which is where everybody else can see it. So we hope it will be loaded in the production site by the end of May. That's our goal with that. So I will certainly let everyone know when that is loaded and live, and provide some instruction and education around that and what you're seeing. With that, the VTE prophylaxis measures, the analytics is actually in Arbormetrics' hands to review. Once they review it, have it with their teams, they'll be able to provide us a timeline of how long they think it will take to build, and then we'll know when we can expect it in the site. I hope it will be available by the fall. That's kind of what I'm thinking for that. Doesn't really affect y'all so much. We'll be able to see it, but they are actually putting a filter in the system site for us, where we'll be able to group data by the 1s and 2s and 3s and 4s, because right now we can only do just the 1s or the 2s or the 3s and 4s singularly. So we'll be able to group those two together from that standpoint. So that's where we are with Arbormetrics. Upcoming meetings, we have the GQuIP kind of virtual meeting that's in conjunction with the TMD meeting coming up on May 20th at 4 p.m. So those appointments have gone out. And we have our summer in-person meeting coming up August 22nd at the Macon City Center Marriott. You'll be getting more information from Gabby on that soon. It will be in the smaller meeting format like we had in November. So we're working on the agenda for that with Dr. Smith and Dr. Ayan Chi and Dr. Todd. The spring 2025 TQuIP reports, you should have received those, our 1, 2, and 3 centers and our PED centers soon, as well as access to our collaborative reports. So we've been going through those. We're also building the performance matrix for that spring report, and you will be getting that from me to fill out, because our goal will be to go over that at the summer meeting for that. So hopefully centers will be seeing that soon from me. One of the things that's on Dr. Smith and Dr. Ayan Chi's radar is they want to do some facility visits or even calls. I know Dr. Ayan Chi had a call with Josie at Navicent. They want to kind of get a feel for, what's going on at centers, how they can help, how they can engage centers. Dr. Smith wants to kind of start with some facility visits, maybe at the level 3s, how they can engage boots on the ground. So be looking for you might get some emails from me, the centers trying to set up some visits So that's one of the things that they're really looking forward to doing from that standpoint. Some good news on the front is I'm going to get a little bit of help. We have a PI specialist role that'll be a contract role that'll be helping me a few hours a month. Well, and we hope to be able to announce that soon. We're just finalizing some contract details with that. Remember, the call for data is actually open for TQIP for our TQIP centers. And with that, your download to GQIP for your first quarter of 2025 is due by June the 2nd. Thank you. I already actually have a couple of centers that have done their downloads and have sent their PRQ data entry reports. So I know, and I don't know if Marie wants to speak to this. I know there's some delay with OEMS and T's download for first quarter for them, but your GQuip download is due by June 2nd for the first quarter. And everyone should have had their update installed to be able to do that. So there should not be any issues there. So let me know if you have any questions or any problems. And I believe that is all I have for a GQuip update.
Thank you, Gina. Appreciate that. Lots of work going on.
Yes, and I'm glad that y'all are finding the RTAC reports useful. Actually, that has been something that I've really enjoyed working with Crystal and the RTACs with. We found some interesting things coming out of that, and I think the good work that our registrars are doing. And seeing that data come back out and broken down regionally, I'm just really excited about that project. So I'm glad y'all are finding it useful and excited to see that grow.
Yes, I am too. It was very good. Like I said, it made me get in there and play with it some, and I was like, "Ooh, I need to call Gina and find out how I need to do this."
Well, not just a little caveat to that. Now, not most of that does not come out of Arbormetrics. Most of that comes out of the central site and is raw data.
Okay.
So, but some of it is in Arbormetrics, and there is a filter for sorting it by county of injury by region,
Right.
and that's how we're doing that. So it's not center specific; it's by county of injury. So
it was nice too to see it compared to all Georgia centers too. To see how your region's doing compared to all the other regions
for those times and those. Yeah. So we'll expand that. I think every iteration will look a little bit different.
Yeah. Well, thank you for that. It was very interesting. Okay, so now we'll move on to our subcommittee reports. We'll start with our education subcommittee, Julie.
Hi, everybody. Good afternoon. A couple of updates from our crew. One thing that I'm excited to announce is every meeting so far this year, we've had at least one new person join. So really excited to see the growth. Emily and I are very thankful for that. So very exciting. Keep up the good work. If you're interested at all, reach out and I will happily add you to the meeting cadence. We meet once a month on the first Tuesday of the month at 11 a.m. A couple of things we're working on. We decided as a group around the beginning of the year that one of our statewide goals would be to increase nurses who are credentialed. So specifically the focus of TCRN. There are multiple sites that have started or have continued doing review courses, and we're kind of pushing that agenda, getting some good feedback there. Our next big goal, of course, is to finalize the process of the STN module that Liz mentioned. So I want to formally thank Kendra and Liz and Lynn for getting it going, but also we're at the very tail end of acquiring it. I know everybody's very interested. By design, it'll be reproducible in the sense that you can make it individualized for your site. But as Liz mentioned, we have agreed with the STN that it is not something that can be shared. So by committing to using it as a trauma center, that does not mean you get to text it and send it to all of your friends. So that was the agreement we became kind of finalized this week. So we're really looking forward to that. So thanks everybody for those efforts. We look forward to seeing how we can use them.
Have you ever used those with noise?
With what? And that's it for me.
Okay, great. Thank you, Julie. For the P subcommittee, Kelly Roker.
Hey, everyone. We continue to have some discussions around whole blood transfusion, and COA is in the MATIC-2 study, so a lot more to come on that as we continue to try to reach our inclusion goals for that big national study. Hopefully we'll be able to bring some good news about whole blood and pediatrics and the safety of it to the state. We are still, our EMS Safe Transport project is still up and running. So if anybody does not have that QR code that links to our REDCap tool, that will help us collect data on safe transport of peds coming to your facilities, please reach out and we'll make sure that you get that. And then we're working on the pediatric transfer toolkit, the one pager. We met with Dr. Vassie to try to make sure that the pediatric one-page transfer reference sheet is in line with what he had approved for adults. So we're close, and it needs approval by the pediatric TMDs in the state, and then we'll get it to Dr. Vassie. And then hopefully get it to Sarah Holcomb, who apparently is a VisMe wizard, which I certainly am not, so that she can pretty it up for us, and we'll be able to get it out to everyone. That's all we have.
Thank you. Yeah, I'm very excited to see the pediatric transfer sheet that y'all are working on, and excited to see that we're working along with our TMDs to get that done. I think that's good movement from all of our parts. So,
Thank you.
Oh, Dr. Vassie is on, and he has a question, or his hand's raised. Go ahead.
Yeah, the only thing I'd add to that, you mentioned kind of getting it to the folks to pretty it up in the interest of kind of making it in line with the adult poster that is in the process of going out. Liz had helped out with the formatting and the branding, so whenever that's ready, I think that'll be a great place to kind of take it through, and we can hopefully we'll go around to some of our referring centers and see them side by side in the ED.
Yeah, that'll be great. As long as there's somebody else who can pretty it up and it's not me, I'm whoever volunteers for that will make me very happy.
Yeah, that's exactly what I said as well.
That's great.
Thank
I'm
you.
looking forward to seeing that. I really think that will be very helpful for all centers, not just our small rural facilities, but I think everybody should get some benefit out of both the adult and the pediatric. So I'm excited to see those. So thank y'all for working so diligently on that. Okay, so our next subcommittee is our process improvement. Raymond.
Good afternoon, everybody. The PI subcommittee, we did put on hold our time to definitive care. We're just waiting for the big group to make decisions and before we move forward with that. So we have started working on a PI playbook. We did a survey from the centers to see what they need, what they feel would be beneficial in this toolkit to get our starting point to put the playbook together. We discussed next steps. I did get a few people send me some things so we can start to build this playbook. I'm still waiting for some more people to share anything that would be helpful. And then we discussed ACS tips for a successful survey as well during our last meeting. So more to come on our playbook. We're excited about putting it together to get help for everybody and not recreate the wheel.
That sounds great. Is there anything in particular that you're looking for from any of the centers for that, or just best practices from them?
Practice, basically. A lot of people wanted, your best practice for having good loop closure and being robust with your loop closure. So that was a common theme on our survey that we did. So that's something we're looking at too. What helps you, what do you use to help you do that? So anything that people can share on that. And then just tools for doing your like reports and drill downs, those kind of things.
Okay. All right. Thank you, Raymond. So next we'll go to Kelly Vaughn with the registry.
Hey, so yeah, the things we've done with registry, we actually had a very brief meeting in April. We have two big initiatives. One is upcoming education for the registrars on the ICD-10 procedures and diagnoses. Gabby and Katie and I have been working with, we're trying to secure a vendor. And as soon as we get that done, they go through the state process. We should be able to talk a little more about that. We are looking at a basic course and an advanced course, and the dates will probably be fall. So just stay tuned. As soon as we know more, hopefully by the end of May, we'll have a good idea. Registrars will get a survey to complete, just like you did with the AIS training, and that helps Gabby. It'll go to Gabby, and she will work with the vendor on getting everybody registered and making sure that moves forward. The other big thing that we're doing right now are some software demos. We have about 30 people out of our group that have been interested in looking at different software systems. So there have been two that have been reviewed to date. I reached out to another today and I'm waiting on feedback from them. So it's just getting an idea of what's out there. I know for those of us that are in V5, that is going to sunset. I know that everybody's in either a verification window or a data abstraction cycle. There's never going to be a great time for all the centers, but I do think we need to look at everything and make a good decision for what may work best for the state moving forward. So that's where we are.
Okay. All right. Thank you, Kelly. Injury prevention, Crystal.
Hey, just before I get rolling, can y'all hear me okay?
Yes.
All right. So happy Trauma Awareness Month again. We are still planning actively, and we'll get some information out to all of y'all to have some trauma system webinars for Stop the Bleed in celebration of National Stop the Bleed Day. So we won't do it necessarily on National Stop the Bleed Days. We will do it May the 19th and the 21st. So Monday, May the 19th, and then Wednesday, May 21st. Just wanted everybody to know that our virtual outreach so far has, since we started 2021, just the Stop the Bleed programming alone, we've had over 8,500 Georgians participate in that. In fact, I looked at the numbers, the virtual stuff. We've had over 8,700 Georgians participate in those virtual webinars, and we'll hit the advertisement really hard next week. Advertising from webinars is generally short-lived, and it's the folks that sign up closer to the end of the registration period that actually end up being the ones that are more likely to attend. So if you feel like you've missed a boat, you certainly haven't. What we do encourage everybody to do, if you can, post your upcoming classes on the national site so people can see community-based courses. If you've got something coming up, and you can also post a skills checkoff session in conjunction with that. So maybe some of these virtual participants can drop in and get their skills checked. I do know we get on occasion people calling us back looking for instructors. And of course, if we find there's a large number of folks from a certain area, we do try to reach out to y'all. At any point in time, if you want to know who's gone through those programs in your area, please reach out and we can pull that information by county. Certainly would appreciate some of y'all, if y'all don't mind, if y'all could sponsor some of the Trauma Llama t-shirts. That would give us 4 prizes for that. They cost about $15 to purchase and then mail out to folks. So really inexpensive way to support that program. For those of you that are instructors in Stop the Bleed, I just want to remind everybody that the new ACS Stop the Bleed curriculum is now available in the instructor portal. The web-based online on-demand program is still out there. It's still a reasonable way to do it, but that program is still the old version of the program. If you haven't taught the new Stop the Bleed or haven't seen the new Stop the Bleed PowerPoint presentation, you'll notice that it's very, very lean. They're very, very sensitive to keeping their instructional property, so they've password protected it, and they're really not wanting us to post it on our various websites. So just kind of keep that in mind. What I would say to everybody is while the underlying message and technique remains unchanged, you'll teach it largely the way you've always taught it. The new presentation is highly visual. There's very little text on the slides. So I would say that if you're onboarding new instructors, you definitely want to teach with them till they become accustomed to what the content is, what the messaging is, so that we can be consistent and just look out and support each other. I would challenge every trauma center, try to, between now and say the end of June or the end of July, try to post at least one public offering on the national site so folks can find those courses near them, because that is where we're going to be directing these people that come through the virtual program. We'll also say that Georgia Stay Safe Week is coming up. That is our firearms injury prevention effort that we do every year for the first week of summer. So the Georgia Stay Safe Week is June 15th through the 21st. You can still access the materials, the activity books, both in color and black and white. You can co-brand them, the various posters you can access at www.preventtraumageorgia.org or www.georgiastaysafe.org. You'll be able to access those materials there. And I know I've had an opportunity both at the last, while I wasn't at the last Georgia Trauma Commission meeting, some of our folks were, and they were passing out some of those books, and we were actually able to give them out. With many of y'all came to Macon recently for the Matter of Balance coaches training. Speaking of Matter of Balance, I want to thank everybody that attended the coaches training that the Middle Georgia Regional Commission hosted in March. It was a great showing of our trauma system, and it's always good to see everybody. We are going to do a follow-up virtual coaches training. Now, those of you that were in the room and those of you that attended the coaches training, there's nothing better than an in-person course, as you well know. But we also want to make sure we're equipping those of you that are coaches with adequate help and support. So if you want to onboard some new instructors to assist you with that program, we're looking at July 5th as being the time for the virtual A Matter of Balance coaches training. Finally, the bingo signs, the statewide bingo signs license renewal will take place in June. I want to express my appreciation to everybody with the Trauma Commission for working very, very hard in the background to try to support that. When we were at the coaches training for A Matter of Balance, we got word that there's been some structural changes taking place within our area agencies on aging, and that the Middle Georgia Regional Commission might not be able to purchase the statewide license this year. And so the Georgia Trauma Commission folks worked very, very hard to be able to get it where they could support the statewide license. But in the background, the area agencies on aging were trying to advocate for that program too. And so the area agencies on aging, specifically the Middle Georgia Regional Commission, will renew the statewide license in June. So we're not going to be onboarding any new people. Everybody that has previously been trained as the facilitator for that program, your status as a facilitator has to be renewed with each license renewal. So we'll all have to go through this renewal process again. So we also met in April and discussed, putting forward a proposal that would help offset some of the cost. And we also have some interest expressed by new centers that want to come on board and do the bingo size program. So we did put forward a proposal to the Trauma Commission for consideration. Of course, it hasn't gone through yet, and certainly now that we know the license itself is taken care of, if for some reason we're not able to get funding this cycle, we certainly understand, but it will be much less cost prohibitive having a statewide license. So the big concern that is costly is the $400+ per organization per county that we're not going to have to worry about in terms of making that program affordable for us. So I know that's a lot of information. Would encourage all of you to log in to the National Stop the Bleed site and go to the instructor portal, get familiar with that again. Go ahead and download and get familiar with the new program. I will say that they're going to use this process of people renewing and people getting on board and attesting that they're data sharing within the system as a way of cleaning up the national instructor list. Keep in mind, if you want to be on the state instructor list that we kind of maintain, so that as we have classes come up and requests come up, we can refer out. You can find that at www.stopthebleedgeorgia.org. The national list is not published, whereas our list, if you decide to be a part of that, is published. And that's all. Sorry.
Oh, that's great. Lots of great information. And lots of work. There's a lot of things coming up for injury prevention. Lots of new weeks and dates and stuff. So thank you for all that, Crystal. Are there any questions for any of our subcommittee chairs before we move on? I know that's a lot of information they just threw out to everybody. No? Okay. So hearing none, we'll go to our next thing on our agenda, which is our standard review. So the first standard that we chose was the 5.3, the levels of trauma activation. This is a type 2 deficiency. It applies to level 1s, 2s, and 3s, and pediatrics 1s and 2s. And it's just lists for your highest level activation, then you must have at least these 8 criteria they have listed here. And then of course you can add as you see fit for your center. And I know we've at our center we've added a few more to these, but the main thing with this one is just making sure you have these 8 listed. And then when they come for your survey, of course, you'll have to show, that you have at least these 8 in your level 1 activations. So that's pretty much cut and dry. Kendra, do you have anything else to add to that one?
No, we do have additional criteria kind of spelled
Yeah.
out for our pediatric patients because we are combined with an adult center, but
Right.
yeah, those just have to be clearly spelled out.
Okay. And then the next one, the 5.4, that's your trauma surgeon response to your highest level activation. This is a type 1 deficiency, so you must have this. Again, this applies to all levels in pediatrics. So this, for your highest level activation, at least 80% of the time, the trauma surgeon must be at the patient's bedside for level 1 and 2 trauma centers within 15 minutes of the time the patient arrives, or in level 3 is 30 minutes. So one thing for this is, this is your trauma surgeons, not your residents. We have a residents here occasionally, and they do with our surgeons, and they do respond to our activations, but it's our trauma surgeons that count, not them. Sometimes that's hard drilling that piece of information to our ED staff, and then the measures of compliance is, showing that report. And this is good, part of our quarterly state report. This is something we have to report on. So I think that's great that we're already reporting on this. So then when we get ready for our ACS visit, this is that you're meeting the standard at least 80% of the time, because we're already having to do it for the state. So anything else for that one, Kendra?
I can't think of anything to add.
Does anybody else have anything else that they do differently? I think these are pretty much cut and dry here. And since we're on trauma activations, we just thought about adding these other two. The 5.5, the trauma surgical evaluation for activations below your highest level. And this is a type 2. And we asked for Josie from Navicent, which is level 1, and then Ashley from Cordell, which is level 3, if they could share what their process for meeting this standard. So Josie, if you want to share y'all's process first.
Yes. So this is Josie from Navicent. So for ACS standard 5.5, it says trauma surgical evaluation for activations below the highest level. For our program, that's the tier 2 and the tier 3. In the standard, it says that the trauma program must define and meet acceptable response time to trauma surgical evaluation for activations other than the highest level. Couple of measures of compliance for this standard. Criteria for lower levels activation where trauma surgical evaluation is required. And the second one is we have to have a report for time to trauma surgical evaluation for lower level of activations. Like I said, our lower level activation, we have a couple, tier 2. Our activation response time should be within 30 minutes, and that's documented in our trauma chart. So that is handwritten. And for our tier 3, the notification to response time of our surgery resident should be within 60 minutes of consult to evaluation time. That information is documented in our HMP. We updated our template for HMP to reflect that. And to evaluate for the compliance of our team, if they are there and documenting it, the PI team, they do concurrent reviews of these charts. And they, if there's any missing documentation, they talk to the squad nurse. If it's a tier 2, if it's a trauma HMP, we talk to our trauma residents. And our registry team, after the abstraction of the data, we do a monthly registry report on these activations, tier 1, tier 2, and tier 3. We're talking about the lower level for tier 2 and tier 3. So we look at every month where we're at. Our goal is greater than 80% for these activations. And that's all I have.
That's great. So you kind of treat it just kind of like your tier 1s, I assume. I mean, treat them pretty much the same way as far as documentation and your reporting. So that's good.
Mm-hmm.
Okay. Thank you, Josie. I appreciate you sharing.
Oh, you're welcome. Thank you all.
Very helpful. Ashley?
Yeah, so we do ours a teensy bit different. So we're a level 3 trauma center, and we are in a very rural area. And most of the patients that come to us, our primary goal is to get them stabilized and shipped out, or we will admit the lower acuity patients that we can handle. So we do have a 3-tiered trauma activation system. So our level 2s, we have a 12-hour maximum time frame that the surgeon has to see the patient. And then for our level 3s, we have a 24 maximum hour time frame that the surgeon has to see the patient. So this is still a fairly new process within the last year or so, year and a half. And these goals were kind of set to meet our specific needs. So every center, as you'll see, has different needs and different things that are suitable for their facility. So our surgical team felt that this was appropriate for us, and we haven't had any bad outcomes related to those timeframes. So very rarely, I will say, does it take our surgeons to see our patients in 12 hours. Most of the time, they are here within a couple of hours anyway. So what we do is we take this data and we log it onto a PI dashboard, and we get the data. So the way I get the times is I do chart reviews And then I do real-time rounding. So when I round on the patients, I'm looking at the chart, making sure that the surgeon has seen the patient within the appropriate amount of time. And then I log it on my dashboard. And then, when the chart is abstracted, that also goes into the registry, in which we could run a report from that as well. If there were ever a time, knock on wood, well, thankfully we haven't had an issue at this time, but if there ever were a time that we didn't meet those goals for some reason, then there would be a peer-to-peer discussion between the surgeons as to what the rationale was, why that particular goal was not met, and they would discuss that, and there would be re-education and then monitoring until your achieved desired goal was maintained for a loop closure. But we have also included this in our trauma response policy as well. So in that policy, we have the time frame that our level ones have to be seen, which is 30 minutes. So we've also included this level 2 12-hour and then the level 3 24-hour in that as well.
Yeah, that's good. They always want to see your policy.
Yes, I have learned that.
Yeah, it's good to have it in there. And it's good to show the reports, you have it in your policy. They want to see, what are you doing with it in your report? So you have some documentation to back that up. So that's great. And like you said, each center is different. That's why we want to kind of hear from different types of centers to see what other people are doing, because we can meet the same standard, but it's depending on our center and levels, how we meet it. So thank you for that, Ashley. That was very helpful.
Thank you.
Does anybody else have anything else, any other comments or processes that they'd like to share on this standard for their center?
Hey, Lynn, this is Jay up at Henry.
Hey.
Had a quick question. Good presentation by both of you. Is there consistency across the state on, we kind of beat around a little bit with the time frames on those, whether, we go 12 and 24, do we go 6 and 20, is there any consistency across the state, especially at our level 2s, level 3s, of that surgical evaluation for the non-single tiers? I was just wasn't curious. People could throw that in the chat or something over the other level 3s on what time frame they decided on. We're leaning very similar to what Ashley just presented on a 12 and 24 time frame. I was just curious if we were on the right track or not.
Yeah, I think that's good, because I think everybody is different. So I'm sure there probably is, but yeah, if you don't want to come off your mute or put it in the chat, just to let us know.
I will say for us, I kind of surveyed multiple different centers, that were level 3, the same level that we were. And I mean, you're right. Every center has a different time frame. So when the TMD and I were discussing it, we just kind of looked at holistically what was in the best interest of our community, our surgical team, because we only have 2 surgeons. I mean, we have 2 surgeons that cover call 365 days. So we kind of had to take in holistically what would be in the best interest for them and for our patients. So that's how we came up with our times. And so far, we haven't had any issues with those specific time frames.
Yeah, no, that's good stuff. Then that's kind of the same discussion we had with limited call, especially when covering ACS volume. Now, we admit the vast majority of ours, 60, 70 a month that we admit to the hospital. So they have a high volume anyway. But I was curious, my second question was going to be, has anybody had an ACS verification as a 3 or 4 and they accepted the 1224? Did they give any feedback that they thought?
Can y'all hear me?
Yeah. Oh, can you hear me?
This is Karen from Cartersville, Piedmont, Cartersville. So I was just looking through our notes. I wasn't here for the survey, but I'm looking at our opportunity for improvement on this specific 5.5 standard. And ours is written for a partial trauma for the consult to be within 90 minutes of the call. And they actually suggested to us to lower it to 60 minutes.
Ouch.
Ours is 60 minutes as well. But majority of our patients are transferred. So if we have a trauma patient that's being admitted for their traumatic injury, then the trauma surgeons need to be here anyway. So we haven't had a problem with that either.
Got it. I guess that'd be maybe a good discussion for even for another meeting.
Yeah.
Do we look at some of the low mechanism, low injury, someone that falls, but then they also have maybe you find maybe it was say broken rib or something like that, but hemodynamically stable, oxygenating well, no problems. And that accident happened at 10 o'clock at night. Do you call your surgeon in to come see them in 90 minutes, or do they see them at 6 o'clock in the morning when they get there and do a full evaluation and tertiary review? That's what we're kind of battling around. Yeah.
Yeah. Yeah. Good discussion. All right. Anybody else have anything on that one? Okay. So our next one, this actually came to me during our last meeting when I had when Chris talked about their ACS verification with at Doctors Hospital. I know this is one thing that they started working on. So we asked Chris if he would come on and talk about their geriatric activation criteria for this standard.
Hey, Lynn, can you hear me?
Yes.
All right, thank you. I have a few recognitions and shout outs, if that's okay.
Yeah, absolutely.
All right, so first, thank you for the opportunity to share our ACS experience. I want to shout out and say hello to Madam STN President Liz Atkins. Congratulations, and it's a pleasure to know and work with you. Crystal.
Yes, I completely forgot to.
That's all right. She's still recognized. Amazing work.
Absolutely. Congratulations, Liz.
Crystal, thank you for coming to our RTAC meeting. That was very special, and you bring a lot of knowledge and support to RTAC. So that was great. Thank you so much. Stacy, also thank you for recognizing us. And I just wanted to shout out a moment to my team, Laura, Shelby, Adrian, for really putting the work in and receiving the zero deficiencies that we had. A lot goes into it, as everybody knows. A little transparency here. When I'm looking at the criteria and the OFI, it's actually listed as 5.3 for us. Now, we will convert this into 5.6 anyway and have it part of our protocols for our injured older adult. So we will kind of incorporate that into the policy anyway. But I'm going to first read specifically what that criteria 5.3 stated for us, and then kind of go through a little bit of our past criteria and what we're moving to. So their statement here was, there is no geriatric systolic blood pressure specific activation criteria for patients over the age of 65. There is no notation about the patient's use of anticoagulants, either under the level 1 and level 2 criteria. They recommend revising the activation criteria to include a systolic blood pressure parameter of 110 for patients over the age of 65. And also consider adding a statement to a level 1 and level 2 criteria regarding the use of anticoagulant / antiplatelet agents as an activation criteria, or at least increasing the level of activation if their use is known. So the problem that we had at the facility, we have this level 2 head strike criteria that didn't really flow well with ACS because it is a different type of response time. Now in there, it does have patients on anticoagulant, antiplatelet, patients suffering from low impact trauma incident such as ground level fall and striking their head with external signs, and GCS of at least 14. So there's a lot of N's in here. That criteria gets very confusing when we're taking those reports from EMS, as well as education for ED and TNL staff. In our regular level 1 criteria, we did have notation of blood pressure confirmed as systolic less than 90 at any time in an adult, but it really wasn't specific to geriatrics. So after receiving that preliminary review before we got this confirmation letter here, obviously we reviewed the geriatric best practice criteria, and in there is 5 bullet points. The first is ground level fall for patients on antithrombotic / antiplatelet agents. Second is systolic blood pressure less than 110. The third is heart rate above 90. The fourth is a shock index greater than 1. And the last one is ground level fall patients not on anticoagulant, but with a GCS less than 14 and signs of head trauma. So after communicating this with our trauma providers and the team here, we're going to adopt all the criteria at this time, but we will exclude the shock index greater than 1 for now, as we're going to look into how we're going to effectively track that from EMS standpoint and education, because it all starts in the field, as well as provision of education to our internal staff, our TNLs, and our ED providers, and see if we're going to migrate and accept and adopt that shock index. But we are working out this criteria now to finalize it, roll it into play with that 30-minute response time. And if there is other injuries associated with this criteria here, then that criteria should be elevated to a level 1. So that's what we were able to kind of get from that criteria with geriatrics.
Nice. That's a lot.
That is a lot. I'm sorry I talk so fast.
No. No, I just know from other centers I've talked to, the ACS is really hyper focused on geriatrics. All other visits too. So I just think this was something good to bring to the group to see, what they're doing with their geriatrics and the activations. And I appreciate you sharing what y'all are doing.
Of course. Now, I do want to bring something up and open to the group because at our center, we obviously do have a high non-surgical admission. And we look at those, review all, and kind of justify those as well. But does anybody else have best practice either to lower that rate or better collaboration with your hospitalist and geriatric liaison?
Anybody want to share what they're doing for that? Or put it in the chat if you can't come off mute. That would be interesting to see what other centers are doing for that, because I know that is an issue for a lot of people. Say, Marie, you have a question or want to say something?
Yes, but I will wait until you close out this discussion item.
Oh, okay.
And you open it to the floor for other comments.
So Ashley Faircloth, she said theirs is high also. Ashley, were you or Tricia going to talk about the same standard as well?
Yes,
Have
ma'am.
y'all had anything else to add?
In regards to the standard, I mean, Chris he really went through it very clearly. And actually in talking with him and his team after their visit, we got a lot of insight. So one of the things that we did is that we went back and we've been working on adjusting our activation criteria to include those best practice geriatric consideration elements, just so that we're recognizing those atypical presentations and addressing them quickly. So that's actually going to be going through our operations this month. And then we've been changing up our guidelines a little bit. I don't know if anyone else's facilities are having this problem, but we're having a problem getting a geriatric liaison. So we're trying to be mindful of pulling hospitalists in for consults, and we're trying to implement frailty screenings and making sure that we're adhering to those. So that's all being built into the revision of our geriatric guidelines, because we are in our reporting year. So we're trying to fix those things and make sure they're tightened up. We also are bringing in a social worker. We're just trying to really optimize that care coordination, make sure that we have that for not just our geriatric trauma patients, but that we're screening all of our trauma patients, but they will have a big focus on our geriatric population, which we all have a high geriatric population at this point. We try to do early med recs. We try to review those comorbs, get those fall assessments. We're currently doing a mobility program with our floor nurses. We're trying to optimize mobility to reduce aspiration and some ICU bounce backs. And we're hoping to have some good results from that to share with the ACS. and just, really hone in on early discharge planning as well. So all of that's kind of getting wrapped up into this revision of our geriatric guidelines that we're working on.
Going back to what Chris was asking with the high admission rate, are you using the Nelson score to stratify it all?
This is Karen at Piedmont Cartersville again. We also have a high NSA rate as well, and we do use the Nelson scoring tool. And I will say during our survey that was also listed as an opportunity for improvement, and they recommended seeking more opportunities to do tertiary survey exams. So we decided to look at the Nelson scoring tool, and on patients that have like a high mechanism of injury or had very low comorbidities, we started putting in 24-hour tertiary surveys on them.
This is Jay again, Henry. We also are working with the Nelson tool. Actually have modified the Nelson tool to be so much the Nelson tool is a retrospective look at, did you do it correctly? We're trying to move it up to the ER physicians. We're calling it a trauma admission scoring tool, but very similar, 0 to 3 would be an automatic admission to trauma. 3 to 6 would be roughly related to a call to trauma to see should we admit this to medicine or to trauma. And then the high numbers do go to medicine, but consult trauma the next day. So if anybody's interested in that, we know it's not perfect, but we're trying to beat it up a little bit and make it a little more usable on the front side. So if anybody's interested or has comments about it, if they've tried it and it didn't work, we'd love to hear that as well.
If you can share the modified Nelson score, I would like to take a look at that because that is great to utilize for appropriateness to the a non-surgical service line, and we can kind of utilize that to offset that high percentage that we have and just justify that. So that would be interesting to look at to see what's the difference between the
Well,
7 score.
So far we're seeing some good success. I'll say
That would be great. Also, Dr. Vassy put in the chat that they use the Nelson and that they limit non-surgical admissions to isolated hip fractures, and they added a hospitalist to their trauma peer review committee as a liaison. We did that as well because our non-surgical admissions, of course, as a level 3 is very high, and mostly it's those isolated hip fractures. So that would be great, Jay, if you can share that with the group for everyone.
Just respond. And we'd love feedback on it. We think so far we're obsessed with it. Takes a little bit of the ambiguity out of the ER physician from trying to guess who to call. It gives a little more teeth in the reduction of the non-surgical admissions. We kind of lose a little sleep over that sometimes.
Yeah, I get that too. All right. Great discussion. Anybody have anything else on this? Okay. Marie, you had a comment?
I do. I just wanted to give some additional information. Gina opened the door for me to say something, but the meeting just rolled right on. But I wanted to let everybody know a little update on the 2025 ESO state update that everyone is waiting for. ESO tells us that they have 90 to 180 days to fully complete the state update and roll it out to you, which means they have until September 10th. If they take it out to 180 days to develop the update for you and distribute it. So if it happens to take that long, I hope it does not. I'm hoping for mid-June, late June at the latest, but you can never tell with bees. So ESO estimates that they would have it out to you at the latest 180 days after we gave them the approval. So If it takes until September 10th, then you will just do your download like you would normally for GQuip and TQuip, and send us your January through June 30th data, which is due September 1st. So we will be caught up at any point that they send out your state update. You can do your download. And once they do send that update out to you, then we will open the 2025 import link on the ImageTrend patient registry site. So you can do your download and import that file. Any questions? Thank you for the time to mention that, Lynn.
Yeah, sure. Thank you for that information too, Marie. Leah's also put in the chat for level 4 centers. Please be sure to complete the feedback form on the revisions to level 4 standards. And she posted the link there. This is from the ACS, I believe. Is that right, Liz?
Yes, ma'am. I'm trying to get in there. Oh, it looks like it just went up. There's a PDF of a list of the standards, and Gina created an amazing list. You actually can't see the definition and the more information section of each standard unless you open up the survey. So I'm going to see if I can drop the document that Gina created. She went through and put all the additional information on each standard. But if you're level 4 center, you're going to want to make sure you review and take a look at that. We're also, Gabby, I believe she sent it already, but we want to try to get, we have a great relationship with ACS through the collaborative. So we're going to try to get all the level 4s, or at least representatives from leadership from the 4s on a call on the 28th to go over like what's giving you heartburn, what's concerning. And then if there's something that just isn't clear that we need reworded, I think they will be interested to know what some system feedback is. And Stacy, April, and Marie, you guys, we need you on that call as well. So you'll be included in that invite. So look for that if you don't have it already.
Thank you for that. I'm glad to see they're finally working on that, and hopefully we'll see that soon for the level 4s.
It's about time, right? It looks like it's in that Word document that Gina created with the additional info. So coming over to you, and sorry that link is so long, but we're not really sure how they got their distribution list. I think it's just kind of random. So
right. Okay. All right. Well, thank you for sharing that. So do we have any celebrations or shared experiences? I know, oh goodness, where'd my list go? I just had it right in front of me. That Stacy said, oh, Liberty Regional just passed their designation. Congratulations. Doctors, when you about them last meeting. Redmond and West Georgia. Do y'all have any anything y'all like to share from your recent surveys for everyone? Congratulations to all of you. I know you're very happy to have that behind you.
Hey, Lynn, it's Rachel. Can you hear me?
Yes. Hi, Rachel.
Hey. I don't have any like key takeaways. I just want to say thanks to Stacy. It was a great experience, and we learned a lot, and there was a lot of collaboration. And thanks to Ashley and Dr. Sutherland who came and did our survey. So we really appreciate it. We learned a lot, and like I said, we collaborated a lot, and we've already exchanged some additional tools. So it was a great experience for us. We really enjoyed it.
Good. Congratulations. All right. Anybody else have anything else to share that we hadn't talked about? Anything at all, because we still have 35 minutes. Or I can give you 35 minutes of your day back. All right. Well, thank you, everybody. I think it's a great meeting. I think we've shared a lot of information with each other. Gabby's got the sign-in link QR code there. Again, please make sure You do that for your attendance. If there's nothing else from the group, someone would like make a motion to adjourn.
That's Rachel. I'll motion.
Thank you, Rachel.
Sure.
Kelly Roker, all motion.
Thank you, Kelly. All right. Well, we are adjourned. Thank you all again. I appreciate your time and attention.
Bye, everybody.
Thanks, Lynn.
Thanks, everybody. Great job.
Yeah, bye.